it's my great pleasure to introduce Dr. Elliot Israel, known to certainly all of you and virtually anyone with even a casual interest in asthma. Dr. Israel heads our Asthma Research Center at the Brigham Women's Hospital. He's a professor of medicine, and he holds the Symboli Distinguished Chair in Asthma Research at Harvard Medical School. And we're delighted that I'm here today to talk about biologics in asthma. Dr. Israel.
Thank you, Chris. It's really a pleasure to be here. And it's a pleasure to be able to review what's really an exploding field in terms of treatment of asthma. These are my relationships in the past year. I've consulted for some of the companies whose products I will be talking about. Chris asked me to talk about biologics in asthma, and what I'm going to do is review the potential pathways for inhibition of cytokines and pathways that contribute to asthma, and talk about biological therapy. So I'm not going to talk about small molecules. This is all going to be therapy related to antibodies used to target these. And I lost my, so for some reason I lost the screen here in terms of being able to use the pointer, and I know you want me to, there we go. Okay, it's back. So what I was going to do is first talk about the pathways of what we understand in terms of what can lead to asthma. And I think if you are not acquainted with it, it's really important to understand that we're now beginning to classify asthma based on what we think are biological contributors to the asthmatic diathesis, and beginning to understand that there really are at least two major categories of asthma, what we call type 2 inflammation and non-type 2 inflammation. And we have asthma that's can be driven by type 2 inflammation, and asthma that can be driven by non-type 2 inflammation. And to understand the biologics that we're going to talk about, I'm going to spend a few minutes going through these pathways. So type 2 inflammation is a type of inflammation that we normally think of as perhaps in a broad category as allergic asthma. It's asthma that involves IgE, involves eosinophils, but there's a lot more to how the IgE and eosinophils get involved in terms of this inflammation. So if we think about antigen, which is the normal thing that we think about that stimulates type 2 asthma or this allergic asthma, but as we'll see in a minute, there are other influences that can actually also produce what appears to be this type 2 asthma. But if we think of the classic kind of presentation, you can have allergen, and allergen can stimulate and this is what I'm showing here is a model of the airway with the lumen of the airway being up here. And allergen can stimulate and cause responses in multiple cells. And there are cells in the epithelium itself, that can produce what are called alarmins, which are responses to antigen stimulation and or things like pollution. And one of the products they produce is TSLP, thymostroma lymphopoietin, which I'll talk about later. But what also happens in relationship to the presentation of antigen is stimulation of T cells, and this is why we tend to call this, originally this was called Th2 type cells, T helper cells, but we now call this type 2 cells. But what can happen is that T cells can be stimulated, and these T cells have CRTH2 receptors on them. And the reason I mention that is that that's another area for inhibition. These T cells, through a process and stimulation of enzymes known as GATA3, can can mature and actually excrete IL-4, IL-5, and 13, which are very important cytokines in terms of type 2 inflammation. In addition, there are these non-T cells, the ILC cells, or the innate lymphoid cells, that can also, through a path through GATA3, can secrete IL-4, 5, and 13. And to get this a little bit more complicated, as you can see here, there's stimulation of these ILCs through another pathway, through IL-25, which can potentially not involve allergen inflammation, but as you can see, can come down this pathway. But the main crux of this pathway, where all these things seem to be centering on, is IL-4, 5, and 13. And why are we interested in IL-4, 5, and 13? Well, IL-5 as many of you know, is a stimulant and a chemoattractant for eosinophils. And eosinophils are part of what we're talking about in terms of the pathogenesis of asthma. IL-4, as many of you know, is important in terms of having in terms of maturation of IgE-forming cells, so that they actually form IgE. And as you know, IgE actually attaches to mast cells, and mast cells secrete many products that we associate with asthmatic inflammation, including leukotrienes, prostaglandins, and additional IL-4, 5, and 13, and IL-9, all of which can end up stimulating the respiratory mucosa and causing smooth muscle to constrict, especially leukotrienes and histamine. In addition, and why are we interested in IL-13? Well, IL-13 actually has a feedback mechanism in which it actually disrupts the epithelium and actually has direct effects on the smooth muscle. So that's all. So that, and IL-13 comes down this way. And just to make this a little bit more complicated, CRTH2 receptors are both on the T cells, on the ILC cells. They're also on the eosinophils. So again, if we start thinking about ways that we want to try to interfere with these pathways, we've got multiple receptors and multiple cytokines. And I've got a little break here in terms of thinking about type 2 inflammation, but it's also worth thinking about non-type 2 inflammation. And this type of inflammation, which I'm not going to spend a lot of time talking about today because unfortunately we don't have a lot of interventions for non-type 2 inflammation, but non-type 2 inflammation tends to be inflammation that is not eosinophilic, not associated with IgE, but rather tends to be inflammation that tends to be associated with eosinophils, tends to be associated with interferon and TNF-alpha, and again, though, can and actually can be potentially downregulated by things like lipoxins, again, which I won't mention a lot today because we're really going to focus on the biologics. I'm going to keep coming back to this diagram as I keep going through the different pieces. And so here's this diagram again, just to illustrate the places. And what I'm going to primarily focus on today are the biologics that target IgE, the target IL-4, 5, and 13, and by inference, target eosinophils. So let me, anti-IgE is a compound that's been around for about 10 years or more, and so I'm not going to spend a lot of time reviewing anti-IgE for you, other than the fact that what I'm going to do today is try to focus a little bit, because I'm going to be presenting data regarding anti-IgE, regarding anti-IL-4, anti-IL-4, 13, and anti-IL-5s, is to try to think a little bit about who these drugs might be used in. Show you what their effectiveness was, but also think about who these drugs might be used in. And so I'll start with anti-IgE, which is kind of an old player, but I think actually there's a little bit of new news about our old player. So anti-IgE, as many of you know in terms of clinically, was studied in patients who had IgE, and you had to have an IgE of greater than 30, and a positive skin test or RAS to an inhalant allergen. And that's the way that drug is actually licensed for use. So all the studies that I'm going to show you, and I'm only going to actually show you one, but all the studies that were done with anti-IgE involved patients who met those criteria. And what those studies in general showed that you could reduce exacerbations by almost 50% of patients, by almost 50% in patients who exacerbate. But who responds to anti-IgE? And so what I did is I pulled the study that's most like the studies I'm going to show you that have been used for anti-IL-5 and the studies that have been used by anti-IL-4, 13. And so and you'll see this over and over again, but I think it's important for you to think about who was actually studied so we can think about who we're going to try to treat. So in the EXER study, patients had to have an FEV1 of 40 to 80%. And in all these slides, I'll generally show you in parentheses what the patients were that were actually enrolled. And so they were actually about 65% of predicted. They had to have that omalizumab entry criteria that I showed you, which was an IgE greater than 30 and positive skin tests to an inhalant allergen or a RAS. And as you'll see in almost every study that I'm going to show you, going forward, they had to have at least one exacerbation in the past year, and on average, these patients had about 2 exacerbations in the past year. They all had to be on high-dose inhaled corticosteroids and long-acting beta agonist, and they had to have poor control. In this study, poor control was defined, this is a little bit before the use of the asthma control questionnaire, so it was defined by beta agonist use and nighttime awakening. And what they showed in this study in general was that there's a 25% reduction in exacerbations in the total study population, and that there's a 20% reduction in exhaled nitric oxide. And just to remind you, exhaled nitric oxide is a pretty decent does a pretty decent job of reflecting eosinophilic inflammation in the airways. And so Hananya and colleagues went back and looked at the EXER study, and they said, who are the patients who respond, who got anti-IgE? And what they did is divided the patients based on their median levels of exhaled nitric oxide, their median levels of eosinophils, and their median level of periostin. Periostin is a product that's produced by the epithelium, frequently in response to IL-13. And what they showed was that, interestingly enough, if you looked at the median level of exhaled nitric oxide, which in this study was 20, that if you had an exhaled nitric oxide greater than 20, you had a 53% reduction in your exacerbations. If you had eosinophils greater than 260, you had a 30% reduction in your exacerbations. And if you had a periostin greater than 50, you had a 30% reduction in your exacerbations. I'll focus on the 50% and the exhaled nitric oxide. Keep that in mind as we go through and think about the other drugs. The most exciting new drugs are anti-IL-5s, and there are 3 drugs that are actually now approved, with one recently being approved in the last 2 months. And these drugs work by decreasing eosinophils, and they work by actually inhibiting anti-IL-5 or its effects. 2 of the drugs work by directly attaching to anti-IL-5. One of the drugs works by actually attaching to the anti-IL-5 receptor. The anti-IL-5 receptor is predominantly on eosinophils. All eosinophils have an anti-IL-5 receptor, but it's also present on basophils as well, and I'll come back to that. So what do we know about anti-IL-5? So I'll tell you that anti-IL-5 therapies had first been used before about 15 years ago and were abandoned because when they were looked at in asthma, it didn't appear that anti-IL-5 improved FEV1, which was the major outcome that people were using in terms of looking at asthma, and it didn't seem to do much in terms of exacerbations. And the problem is that we need to understand that we want to be more precise and follow kind of what I call the Willie Sutton rule, which is when Willie Sutton was asked why he robbed banks, he said he robbed them because that's where the money was. And if you're going to use an anti-eosinophil therapy, you need to go after people who have eosinophilic inflammation. And so what Halder and his colleagues and Nair and his colleagues did, as I'll show you in the next slide, is they said, gee, these drugs didn't work for asthma, but they weren't looking at asthmatics who had eosinophilic inflammation. And so let's look at patients who have eosinophilic inflammation. And since we think that what eosinophils do is cause exacerbations, we should look at exacerbations as our outcome, not necessarily at FEV1. And so in a proof of concept study, they actually showed that when they looked at patients who had high sputum eosinophils, and these are exacerbations here on the ordinate. These are 12 months of treatment. You can see there's a very significant, a 50% reduction with mepolizumab, which is the first anti-IL-5 therapy that was approved for treatment in asthma. This is Nair's study. Again, they showed a very significant reduction in the exacerbations. This is the patients without exacerbations. You can see by the end of this, by the end of a half a year in this study, almost 90% of the patients had exacerbations, while the mepolizumab group had much, much less reduction in exacerbations. So these are proof of concept studies. And the biomarker effects that they showed in these proof of concept studies were that the eosinophils dropped. They dropped by 90% when they used anti-IL-5 therapy. There was no change in exhaled nitric oxide and no change in IgE. And so this study, the mepolizumab, was the first drug that was eventually approved for asthma. And I want to take you through this because one of the questions that we're frequently going to get asked, and which I'm going to come to at the end, is the question of which of these anti-IL-5 therapies should I use in which patients? I was debating about whether to give away the answer because of the, so I'll leave you in suspense, but we'll see it as it goes along. So, and in each of these cases, I'm going to explain to you because there are no head-to-head studies, and it's very unlikely that head-to-head studies will be done in the case of these drugs. So in each of these cases, I'm actually going to spend a little bit of time going through what kind of patients were enrolled in those studies, so you can try and interpret what the effects were that were observed. So the DREAM study was the first study that was done with an anti-IL-5 therapy in a large population. They chose patients who had exacerbations, and to get into this study, you had to have had 2 or more exacerbations in the past year. The average number of exacerbations reported by the patients enrolled in these studies were actually 3.5. So these were patients who had 3 to 4 steroid-requiring exacerbations in the prior year. They had to have refractory asthma on high-dose inhaled corticosteroids. So they had to be symptomatic. And they had to have one of the following. They had to have a 12% improvement in FEV1 in the prior 12 months. And when you looked at that population, they had a 20% improvement on average to beta agonists. They could have a positive methacholine, or they have 20% variability in FEV1. And to get into this study, you had to have an eosinophil count of greater than 300, or a sputum eosinophil count greater than 3%, or an exhaled nitric oxide greater than 50. So the mean sputum eosinophils in this count were 280. Sputum eosinophils were done in a very small group of the population, so I didn't report them. And the exhaled nitric oxide, which was done in the entire population, the mean was approximately 30. And what did they see? This was with intravenous mepolizumab, which is not the drug that's used, but it was part of the approval. And what you can see is that this is the placebo group. This is rates of exacerbations here on the ordinate. What you can see is that there's actually, and this is time from the start of treatment, and you can see that there's a significant rate of exacerbations, number of exacerbations, which is dramatically reduced in the patients who were on the different doses of therapy. And you can see that there doesn't appear to be a very significant difference in the rates of exacerbations between the different doses of therapy. So these drugs were being used primarily to, the primary outcome was exacerbations, but they obviously looked at other things that we looked at. And so the first thing is, well, what happened in terms of the eosinophils? And as I told you, the eosinophils fell dramatically. They were first assessed at 4 weeks, and you could see that the eosinophils were dramatically reduced by 4 weeks. And they stayed low throughout this. These drugs actually, once you come off them, eosinophils come back up. And usually within, most of these drugs are administered monthly, although some of them are administered every 2 weeks. And eosinophils come back up usually within 2 to 3 months, back to their baseline levels. What people wondered about was, would FEV1 improve? And at least in this first study, there wasn't a really big difference in FEV1, and there wasn't any significant difference in FEV1 in this group of patients. So the blue line represents placebo, the red line, blue line, the green line, the purple line represent the interventions, and you can see that they don't look any different in terms of FEV1. Asthma quality of life questionnaires, which is looking at symptoms, and again, not a significant difference between the treatment and the placebo group. So the first take on these drugs were, hey, these drugs improve exacerbations, but they don't really improve FEV1, and they don't really improve symptoms. And again, a lot of the theme here is to kind of think about who you treat. And so what they did is they modeled the treatment effects in these patients, looking at patients who had reported having 2 exacerbations, patients who had reported 3 exacerbations, patients who had reported 4 exacerbations. And they showed what the effect was in terms of this is the placebo group and this is the treatment group, and they showed what the effect was based on the level of eosinophils when these patients entered the study. And what you could see is that if you had only 2 exacerbations, there really wasn't much of a difference in exacerbations until you got to patients who had about 300 eosinophils or so. If you had 3 exacerbations, you could see that actually at lower eosinophil levels, there was already a difference in terms of rates of exacerbations, and a very significant difference in terms of patients who had 4 exacerbations, suggesting that there's an interaction here both between level of eosinophil and the rates of exacerbations. So that was the first trial with the intravenous form. The actual study that was done for approval was something called MENSA, which was done with subcutaneous mepolizumab. And again, to just think about it, is asthma uncontrolled on high-dose inhaled corticosteroids plus ALABA. The ACQ, or the Asthma Control Questionnaire value, is 2.25, which is fairly high. 1.5 and above is considered uncontrolled asthma. The patients had to have 2 or more exacerbations again, and again, the average exacerbation was 3.6. They had to have peripheral eosinophils of greater than 150 or a history of greater than 300 in the prior year. The average eosinophils were about 300. They had to have an FEV1 of 80% or 90% if they had a ratio that was low, and their FEV1 was about 62% of predicted. And they had to have at least one of the following: 12% bronchodilator response, methacholine response, or 20% variability. And when you looked at the population, oops, I don't know what I did there. When you looked at the population, they actually had a 25% bronchodilator response. And so what happened in this study? What they showed was that if they administered mepolizumab subcutaneously and intravenously, in both the cases, they reduced exacerbations by 50% or more. And in this case, when they actually looked at this population, they actually showed that they were able to improve the FEV1, although not by a lot. So the mepolizumab increased FEV1 by about 100 cc's, 5.5% compared with placebo. Just to remind you, patients who got into this study had a 25% bronchodilator response. So this is 1/5 of the bronchodilator response that you can get with a beta agonist. So again, these drugs are not particularly working on airway caliber, although there's an improvement there as well. It also turned out they did a study to look at patients who are on oral corticosteroids, because most of these studies had not done patients with oral corticosteroids. And so this was an oral corticosteroid tapering study in which they took patients who had eosinophil counts, I believe, greater than 100, who were on oral corticosteroids, and looked at the ability to reduce oral corticosteroids. And what they showed is that they could reduce oral corticosteroids by 50%, and about 50% of the patients who had not been able to come off oral corticosteroids were able to come off oral corticosteroids. In addition, even in the context of reducing the oral corticosteroids, they were able to decrease exacerbations even as they were reducing oral corticosteroids. So that's the data with mepolizumab, which is the first of these drugs to be available. Mepolizumab is a once-a-month subcutaneous shot. The other drug that became available afterwards was something called reslizumab, which again is an anti-IL-5 drug, and that's a drug that's administered intravenously, and this is a weight-based drug. So it's actually a variable dosing, and it's 3 milligrams per kilogram per month. And in the study for reslizumab, it was done in a slightly different population. The population did not have to be on long-acting beta agonists. They just had to be on moderate dose inhaled corticosteroids, although 85% of them were on long-acting beta agonists. They chose patients who had to have an eosinophil count greater than 400, and their average eosinophil count was 620. Remember that the average eosinophil count in the MEPO studies were about 300, 400. Remember that the greater your eosinophil count, the greater the response to the drug. These patients had to have an ACQ-7 of about greater than 1.5, and their ACQ was 2.6. And they had to have 1 or more exacerbations. So remember, while they increased the eosinophil count here, they decreased the number of exacerbations. So as opposed to about 3 exacerbations on average, these patients had 2 exacerbations. And they, again, had to have a bronchodilator response, so they had to have and these patients had a 25% bronchodilator response. So reslizumab did about the same thing as mepolizumab. It reduced exacerbations by 50 to 60%. This is the ordinate. Here is the percent of patients having exacerbations, and what you can see is that there's a significant reduction in these exacerbations. It also improved FEV1, and so the improvement in FEV1 was 120 cc's, which was 6.5% of the baseline FEV1. And remember, these were patients who had about a 25% improvement to bronchodilator, so about a quarter of the about a quarter of the improvement you can get with a bronchodilator you got with this drug. Remember, these aren't direct bronchodilators. So this is the change in FEV1. In addition, they showed that they could actually improve symptoms. And so the Asthma Quality of Life questionnaire, which is a questionnaire that's used to assess symptoms, was shown to improve in this patient population. The third drug that acts on the IL-5 pathway is benralizumab. And as I mentioned to you before, as opposed to working on IL-5 directly, as opposed to being an antibody directed at the anti-IL-5 cytokine, benralizumab actually attacks the IL-5 receptor. And because it attacks the IL-5 receptor, it would be effective, and it fixes complement, so it actually results in the destruction of the cells to which it attaches. So it destroys eosinophils. It also destroys basophils, which express the IL-5 receptor as well. So theoretically, one might hope that there would be perhaps a greater effect from benralizumab than there might be from the other two anti-IL-5 drugs. But let's actually look at what happens. So benralizumab was, there were two studies done to get approval. They were called Sirocco and Kalima. They were published just 2 years ago. And again, so to get into these studies, you have to have 2 exacerbations on medium to high dose inhaled corticosteroids and a long-acting beta agonist. The average number of exacerbations was 3. There are patterns that are repeating here, as you might notice. The ACQ had to be greater than 1.5, and again, the ACQ was 2.9, which is quite high. Reversibility had to be about greater than 12%, and the reversibility here was 20%. And they, in this study, the primary analysis was on patients who had an eosinophil count greater than 300, but they enrolled about 50% of their patients, or about half as many patients, with eosinophils less than 300. And the average eosinophil count was 470 in the high-dose group and 150 in the low eosinophil group. And the FEV1 here was about 58% of predicted, 1.65 liters. And so in the next 2 slides, I've put the 2 studies side by side. So it's a Sirocco and Kalima. And in this case, what I'm showing you is benralizumab was being tested as a Q4-week drug and a Q8-week drug with administration of the first 2 doses in the Q8, administration of the first 2 doses every month, and then subsequently every 2 months. And again, this is a shot, not intravenous. And what I'm showing you is the data for Sirocco, and I'm showing you the data for Kalima. I'm showing you the data for patients who had greater than 300 eosinophils per microliter when they came in, patients who had less than 300 eosinophils per microliter. The green lines here are the placebos. The Q4 is the 4-week. The Q8 is the 8-week after 2 months of Q4. And these are rates of exacerbations. The numbers here in red are the percent reduction in exacerbations that occurred in these patients. And so what you can see is for patients who had greater than 300 eosinophils per microliter, there was, depending on which study you did, anywhere from a 28 to a 51% reduction in exacerbations. Interestingly enough, the Q8 looked about as effective as the Q4. And in patients who had less than 300 cells per microliter, there was a reduction in exacerbations. Remember, the average entry exacerbation rate here was 3. And so, and remember, if we looked at that predicted line, if you had 3 exacerbations, you'd think that patients who had eosinophil counts less than 300 might respond. The response was a little more variable. Here, the Q8s didn't produce a significant change in one of the studies, but another study produced a 40% change. So again, you've got about a 40% reduction in exacerbations in the eosinophils less than 300. But again, in patients who had on average 3 exacerbations. And what about FEV1? So benralizumab increased the FEV1 in patients with eosinophils greater than 300 by about 100 to 150 cc's, and the bronchodilator response was about, in these populations, about 370. So again, you're seeing about a improvement in FEV1. That's about a quarter of the improvement to bronchodilator. And in the patients whose eosinophils were less than 300, there was no significant improvement in FEV1. The same type of signal was seen in relationship to symptoms. And benralizumab was also tested in an oral corticosteroid-sparing study as well that was published in the New England Journal last year. And what you can see is that so this is a study where patients were initially taken off their long-acting beta agonist and then taken off their oral corticosteroid. And what you can see is that this is the mean change in the oral corticosteroid dose, and you can see the patients who are on placebo, as they got taken off their LABA and their inhaled corticosteroids and their oral corticosteroids had to go back up, and the patients who were on the drug did not. And these are the rates of exacerbations. This is the placebo group. You can see that rate of exacerbations, and you can see that the exacerbations were less in the patients that were tapered, even though these patients were being tapered off oral corticosteroids. So these drugs are actually very effective in patients who have eosinophilic inflammation. Remember, prednisone reduces eosinophils, so the entry criteria for these studies have generally been eosinophil counts of 100 to 150. So what I'm suggesting to you is that for the IL-5 therapies, exacerbations and blood eosinophil counts are predictors for a response to anti-IL-5. Are there any other predictors of a response to anti-IL-5? The FeNO data have generally not been included, although the data seem to suggest that FeNO might actually be a fairly good predictor. It looked like patients who had a greater response, patients who are on baseline oral corticosteroids in the studies that were being done with mixture of patients with oral corticosteroids and inhaled corticosteroids, it looked like patients who were on oral corticosteroids were the ones that were even more responsive. And that makes sense, because generally you maintain patients on oral corticosteroids because they're responding. And one of the most significant effects of oral corticosteroids is their ability to lyse eosinophils. So patients who are on oral corticosteroids and have been maintained are probably those who in general need oral corticosteroids and probably are the ones who are more likely to respond. There's another responder analysis which I didn't include, which suggested that patients who require inhaled corticosteroids and who fail when they taper inhaled corticosteroids are also more likely to respond. Again, suggesting this relationship between inhaled corticosteroids and suppression of eosinophils. So the other question that everybody asks is, should you switch from one to another? So if I take a patient who I put on one of these anti-IL-5 therapies and they fail, should I bother putting them on another? And I don't have a good answer for you. There's one study that was published, which is a really small study from the Canadian group from Presmoro and Nair, in which they took patients. They had patients who had been in the mepolizumab trials, and who also they could give reslizumab to, and they had a group of patients who had been in the mepolizumab trials and had not responded well. And a year after they had finished the mepolizumab trial, they took those patients and put them on reslizumab. They first put them on placebo for 2 months and then put them on reslizumab, and their belief was that that mepolizumab at its approved dose might not actually totally eliminate eosinophils, and it might not eliminate eosinophils in the tissue. And their thought was that using reslizumab, which is weight-based, might actually allow for greater circulating anti-IL-5 and might allow you to eliminate eosinophils in compartments where you might not have been eliminating them with one of the other drugs. And so this is their data in their 10, these are patients who are on oral corticosteroids, and they tried to reduce their oral corticosteroids when they were on mepolizumab and when they were on reslizumab. And they looked at what happens in terms of in terms, I'm sorry, they weren't reducing their oral corticosteroids. They were just looking at sputum eosinophils and blood eosinophils. The left set of graphs here is sputum eosinophils. The right set of graphs here is blood eosinophils. The left side in this graph is pre-mepolizumab and post-mepolizumab. The right side here is pre-reslizumab baseline, post-placebo for the 2 months, and then post the 6 months or 4 additional months of reslizumab. And what you can see is, so in this group of patients that were chosen because they hadn't had as great a reduction in their eosinophils, you can see that their blood eosinophils on mepolizumab were reduced, but not reduced as much in this group. You can see that they're a year later, when they were now going to be put on reslizumab, you can see that their eosinophils were high, and you can see, at least for this weight-based dosing, they were able to reduce the eosinophils significantly. This is in the sputum. So there's actually was a very significant difference between the reduction in sputum in these patients who were put on mepolizumab, who had not responded well, and then put on reslizumab. Blood eosinophils were actually not that different, interestingly enough. So here you can see this is blood eosinophils before mepolizumab, blood eosinophils after mepolizumab. You can see that there's a very significant reduction in eosinophils, in blood eosinophils on mepolizumab. And you can see that in reslizumab as well, there was a significant reduction, but the reduction in blood eosinophils did not appear to be different. So their hypothesis is that perhaps dosing, rather than the particular compound, might be important, and that it's possible that patients may not get reduction in one compartment versus another. They also looked at FEV1 and the asthma control test, and interestingly enough, what you can see is that they weren't able to demonstrate a difference in FEV1 between using mepolizumab and reslizumab, so suggesting that it's not only compartments, but we actually may see different outcomes for different indicators. But in terms of symptoms, though, there actually was a difference, although, again, looking at these data, I don't think that that's a big difference, even though they achieve statistical significance. So what this does suggest is that it's possible that if patients don't respond on one therapy, they might respond on another, and that perhaps the ability to give a larger dose might be helpful. So while I'm showing you these different studies, what are the take-homes that you might take? I think uncontrolled eosinophilic asthma, despite compliance with high-dose inhaled corticosteroids and a controller, with a history of 2 or more steroid exacerbations, who have eosinophils greater than 300, are probably patients that have a high likelihood of responding to these therapies. For 3 or more exacerbations, you may actually want to think about even going to a lower eosinophil level because those patients look like they respond. You have to. The other thing is, in patients who are on steroids, you need to think about looking at a history of eosinophils to see whether those patients might be eligible. You may want one of the problems with these therapies, both anti-IgE and the anti-IL-5 therapies, is that they're quite expensive. They're probably anywhere in the range of $30,000 to $50,000 a year. There isn't any indication that once started that patients will come off. This isn't a suppressive therapy that actually changes things. You have to keep using it. As I mentioned, once you come off for 3 months, you're back to the same eosinophil levels. So there are, in some of the, for instance in Europe, they're insisting on demonstrations of adherence. And so one of the ways to look at adherence is to look at exhaled nitric oxide and see whether you can still suppress exhaled nitric oxide. And that's something that we're actually talking about doing here. Eosinophils should drop in 1 month. So in the rare case that you have somebody who's resistant, you can check the eosinophils in 1 month. How long should you try patients on these therapies, which is another question we get. And it generally looks like the effects are really they're actually achieved within weeks in terms of reducing eosinophils. Patients who respond generally feel better quite quickly, and you can go for longer if you want to look at reductions in exacerbations. And it's really unclear whether the formulations will differ in terms of their effect on lung function or in those who are obese. I want to move on to therapies that are not yet approved, but are really are in the cusp of being approved. And one of them is targeting anti-IL-13 and IL-4. So back to my figure here, and again, type 2 inflammation. And remember, I told you about IL-4, 5, and 13. We talked about IL-5, but what I'd like to talk about is now drugs that block IL-13, and I'll show you also drugs that simultaneously block IL-4 and 13. And so remember, IL-13 is supposed to have effects on epithelium and on airway smooth muscle, and IL-4, as you remember, is responsible for production of IgE. So a drug which was tested but is no longer being developed, but I think can tell us a little bit about what happens with these cytokines is lebrikizumab, which is an anti-IL-13. And so the study for this drug was an ACQ greater than 1.5 on low-dose inhaled corticosteroids with a 12% bronchodilator response. And the characteristics were these patients had a 25% bronchodilator response and exhaled nitric oxide of 30. And they broke these patients out by patients who had high periostin. Remember, I mentioned to you that the epithelium produces periostin in response to IL-13. And what they showed was that in the group in general, they got an improvement in FEV1, but if they restricted themselves to patients who had a high periostin, they got an even greater improvement in FEV1. So suggesting, and when they looked at patients who had a low periostin, they showed that they got practically no improvement at all. So again, here's a potential biomarker for an IL-13 drug. The other thing that's interesting, and the reason I show you this, even though the drug is not being developed, is that anti-IL-13, remember I mentioned IL-13 works on the epithelium, and IL-13, in addition to causing the epithelium to produce periostin, also turns on nitric oxide synthase. So IL-13 stimulates nitric oxide production, and so anti-IL-13 did what it was supposed to. It actually decreased exhaled nitric oxide, and interestingly enough, what it did do as well was it increased the eosinophils, which was not an expected effect. So blocking IL-13 for reasons that are not clear actually tends to increase the eosinophils. And the suggestion is that there's probably a feedback mechanism which results in that phenomenon. I mentioned to you, though, that you can inhibit IL-13, but you can also inhibit IL-4. And it turns out that the receptor for IL-4 and IL-13 shares a component. So something called the IL-4 receptor alpha. So this is the receptor for IL-4, and this is a receptor for IL-13. In this cartoon, what you can see is that the receptor is composed of IL-4 receptor alpha, and in this case for IL-4, it's also got a gamma epsilon component. And in the case of IL-13, it's got an IL-13 receptor alpha-1 component. So it turns out that you can block the IL-4 receptor alpha, so this component of the receptor, and you can get two for the price of one. You can block the IL-4 receptor, and you can block the IL-13 receptor. So dupilumab, which is a drug which has been approved for atopic dermatitis, simultaneously blocks IL-4 and 13. And so what does that mean? So remember, we were interested in terms on the type 2 inflammation. We talked about IL-4, 5, and 13. And so what we're doing here is we're blocking IL-4. We're blocking the maturation of T cells, B cells rather, and their production of IgE. And simultaneously, we're blocking IL-13 and its feedback onto the airway smooth muscle and onto the epithelium. And so dupilumab has been tested in a phase 2b study. The phase 3 studies are going to be published in another month. But in the phase 2b studies, they studied patients who are on medium to high dose inhaled corticosteroids plus a long-acting beta agonist. They studied patients who had an FEV1 of 40 to 80% of predicted, and so their FEV1 is about 1.8 at about 60%. So again, this is similar to what the other study showed. Patients were poorly controlled. Their average ACQ was 2.7. They had to have reversibility of greater than 12%. They did not report the reversibility, so I can't tell you what it was, but based on everything else we've seen, it's probably 20 to 25%. And these patients, as opposed to other studies, most of the other studies which required 2 exacerbations, These studies required 1 exacerbation, but on average, patients had about 2. And they stratified patients by eosinophils greater than 300, about 40% of their population, and those had an average eosinophil count of 600. The eosinophil count of 200 to 300 was about 170. I'm sorry, the eosinophils less than 300, the 2 groups together had about an eosinophil count of about 170. And so this is what they showed, and what I'm showing you in this is the overall population, the eosinophils greater than 300, and the eosinophils less than 300. And this is FEV1 and FEV1% change. And what they showed, remember I'd shown you with IL-13 that there's an improvement in FEV1, and so no surprise, for the overall group they actually showed that there was an improvement in FEV1 compared to placebo, the red line's placebo, and with their different doses. Their best response was a response given to the drug given every 2 weeks. When they looked at, when they divided their population up by eosinophils greater than 300 and eosinophils less than 300, they still saw a significant effect. It was larger in the eosinophils greater than 300. There was a 16% improvement in the FEV1, and when they did it in eosinophils less than 300, this is an 8% improvement in FEV1. So remember, in these other studies with the eosinophils greater than 300, we were seeing a 4 to 6% improvement in FEV1, about a quarter of the improvement to bronchodilator. This drug looks like it's actually probably going to have more of an effect on FEV1 than the others. We'll see what happens in the phase 3 study that's going to be released, but at least based on these phase 2 data and the prior lebrikizumab data, it looks like things that target IL-13 may give you a greater improvement in FEV1 in patients who are type 2 high, which is eosinophils greater than 300. What they also showed was that they got a significant reduction in exacerbations. So given every 2 weeks, in this phase 2b study, at the highest dose, they were able to reduce exacerbations by 80% in the patients who had greater than 300 eosinophils. What was interesting about this study was that in patients who had eosinophils less than 300, they still were able to show a reduction in exacerbations that was significant. That was a reduction by 60%. This is a phase 2b study, so we'll need to really look at a larger group to see whether this effect in patients who have low eosinophils and less T2 actually holds up. What about the biomarkers? So remember, I told you that for IL-13, we saw there was a trend toward reduction in FeNO. And in this case, they actually saw a reduction in FeNO by 16 to 40%. They did see a rise in eosinophils again. And what I didn't put down here is that, and I don't think they measured it in this study, well, one would expect that one would see, or they didn't report it, a reduction in IgE because of the ability to block IL-4 and maturation of the B cells that produce IgE. And as I mentioned, dupilumab has already been approved for atopic dermatitis, so it's highly likely that that drug will be approved as well. The next drug is one that's earlier on, but I think is really interesting in terms of thinking about what's going on. So this was a study done in phase 2 for anti-TSLP. And remember, TSLP is what I called an alarmin. And so it can be stimulated by both type 2 inflammation, but also non-type 2 inflammation. And it's very up early in the pathway. And so last year, a study was reported with anti-TSLP using medium to high dose inhaled corticosteroids. So half of them on medium dose, half of them on high dose with ALABA. 2 asthma exacerbations in the past year, an FEV1 of 40 to 80%, a 12% bronchodilator response, and again not reported as to what it was, and a high ACQ. And this actually shows you what the effects were when they looked at patients who, they used 3 different doses of what's called tezepelumab, which is anti-TSLP. So the blue bars are low dose anti-TSLP, green bars are medium dose, and the yellow bars are the high dose. What you're seeing here on the ordinate is the rates of exacerbations, and what you're seeing broken out here is three different types of ways of assessing type 2 inflammation. They looked at patients who had blood eosinophil counts less than 250 and greater than 250. And what you can see is that the rates of exacerbation seem to be reduced significantly in both groups. I would point out to you that as opposed to what we've seen in prior studies, there was very little difference in the rates of exacerbations between the patients who had eosinophils less than 250 and greater than 250 in the placebo group. So you're seeing here about 0.6 exacerbations versus 0.7. And if you remember the other graphs, in every other study that's been done, the patients who had higher eosinophils had significantly higher rates of exacerbations. And so one wonders whether the fact that one saw such a robust effect on exacerbations, even in a low T2 group, might be related to the fact that there's something funky going on in terms of the different populations. They looked at exhaled nitric oxide, and this looks a little bit more like what you'd expect. Patients who had an exhaled nitric oxide greater than 24. I'll remind you that for anti-IgE, the break was greater than 20. So here, greater than 24, which is even higher. You can see a high rate of exacerbations on placebo, these two gray lines, lower rate in patients who have a lower FeNO, and you can see that there's still a reduction. There's a very large reduction in the patients who are high T2s defined by nitric oxide. There's a reduction, which is still significant, in patients who had a low nitric oxide. But again, remember that you had to have at least two exacerbations to come into the study, and on average, patients had 3 exacerbations. They also looked at if you were T2 low, either by Ig less than 100 or eosinophils less than 140, and showed that that group was reduced as well. What did anti-TSLP do? So interestingly enough, this one was was a full house. It reduced blood eosinophil counts by 40 to 60%. It reduced exhaled nitric oxides by 30 to 50%, and it actually reduced serum IgE by 10 to 20%. So you're affecting all the different parts of the T2 pathway. So I spent a lot of time on T2. I mentioned to you when I started that there isn't much for non-T2. I'm just going to show you data on a drug that is not being developed anymore, which is an anti-IL-17. And so our thought is that IL-17 actually plays a role in terms of maturation of neutrophils and stimulation of in response to non-type 2 inflammation. So when an anti-IL-17 drug was used, it was basically non-effective. When they went to look at patients who had a 20% bronchodilator response, in a post-hoc analysis, they suggested that the FEV1 was better, or the ACQ was better in patients who were treated with anti-IL-17. They subsequently did a study in a larger group of patients looking at that, patients who had greater than 20% bronchodilator response and weren't able to show an effect.
Elliot,
Yeah.
how did they make sure that those patients had non-type 2 inflammation?
So they actually, they did not. So that's part of the problem. So they did not look, it's a great question, they did not look for patients who either had sputum neutrophils or patients who had low eosinophils. Sorry?
Seems kind of dumb.
It does. So maybe somebody will buy that drug and try it again. And so just to tell you about approaches in development, so I showed you when I first showed the slides that CRTH2 is a receptor on multiple drugs on the T2, on multiple cells on the T2 side. And so that's a drug that's in development. And there are phase 3 studies that are being done with anti-CRTH2. Anti-IL-33, so I'll show you. Anti-IL-33, so this is a potentially non-T2, although IL-33 potentially crosses both T2 and non-T2. As you can see, it can stimulate ILCs, these the innate lymphoid cells, which do produce all the T2 cytokines, but it also can stimulate cells, Th17 cells as well, so potentially could be effective on both sides. Anti-IL-6 is potentially being looked at. IL-23 which is another alarmin produced by the epithelium, is also being looked at. And anti-IL-25 as well. Mast cell inhibitors, we published a study in the New England Journal last year where we showed, this is not a biologic, but where we showed that you could use imatinib, which is a tyrosine kinase inhibitor, and improve FEV1 in severe patients. And lipoxin agonists, which might turn down non-type 2 inflammation, are also being used. So what are the conclusions? Monoclonals targeting IgE, the IL-5 pathway, and the IL-4/13 pathway reduce the risk domain of asthma, so exacerbations in patients with recurrent exacerbations and persistent type 2 inflammation. Blood EOs clearly seem to differentiate patients who are more likely to respond. Possibly exhaled nitric oxide can be a good predictor of responsiveness. There's no substantial evidence to favor one anti-IL-5 therapy over another, although high T2 patients who fail one may respond to another. For anti-IL-5 therapy, those most likely to respond have a history of 2 or more exacerbations and eosinophils more than 300. Those with more exacerbations have a higher likelihood of response, either at lower eosinophil levels. Patients on chronic prednisone should be considered at lower levels of eosinophils. Exhaled nitric oxide really might be a very good marker for those who respond to anti-T2 therapies. It just hadn't been the focus of these studies, but when it has been, it looks like it's as good, and in some cases maybe even better. It's not clear, although we all think about eosinophils and anti-IL-5, it's not clear that anti-IgE is less effective than anti-IL-5 in similar classes of patients. Remember, that's that first study where basically if you had high eosinophils, you responded to anti-IgE. If you had a high FeNO, you had a 50% reduction in your exacerbations. The effects on biomarkers are different, and so we need to keep that in mind. Anti-IgE reduces free IgE, but we can't measure free IgE by commercial tests. It doesn't reduce bound IgE, which is what happens to all the IgEs. Anti-IL-5 reduces eosinophils, but doesn't reduce exhaled nitric oxide and doesn't reduce IgE. Anti-IL-4 receptor alpha, so the anti-IL-4/13 reduces exhaled nitric oxide and IgE, but at least initially there's a rise in eosinophils. Anti-TSLP is, as I said, the full house. It reduces FeNO, eosinophils, and IgE. So what it suggests is that some therapies targeted at more proximal parts of the pathway or redundant parts of the pathway, the way IL-4/13, may be effective with lower levels of T2 type inflammation, but this really remains to be confirmed in larger trials. And the approaches for patients with severe asthma with non-T2 inflammation are still, that's the area of unmet need. I'll stop there and take questions. Thank you very much.
Thank you very much. We needed your wisdom to go through this complicated area, so thank you. Carolyn, do you want to start? Carrie?
Have you ever used anti-IgE and anti-IG5 therapy together?
Yes, not particularly on purpose. So the question was, have you ever used anti-IgE and anti-IL-5 therapy together? They work differently. So you could imagine that there are patients who are very, who are IgE and eosinophilic. I have one patient where we did this. The problems are one, insurance. So most insurances won't let you do this. And then there's a theoretical concern of giving people dual antibody therapy. But the patient who we did it in was a patient who'd had a decent response to, well, it had some response to anti-IgE, but was still not coming off her corticosteroids. So she'd had a reduction in exacerbations. She had a lot of seasonal exacerbations, but she was also eosinophilic and couldn't come off her oral corticosteroids. And so I put her on anti-IL-5 and did not want to take her off anti-IgE because she'd had these seasonal exacerbations. She actually responded very nicely. She's been able to reduce her oral corticosteroids, and she's a patient I've followed for 10 years. So it was, and actually we just, this month, we're going to stop her anti-IgE and see what happens.
I have a question. Is there something there? What are the long-term risks?
Good question. What are the long-term risks? So, people say, why do we have eosinophils? And, the ability to expel helminths is reduced by eliminating eosinophils. And so in almost all these studies, patients who'd been in Africa or might be at high risk should actually be looked at to be sure that they don't have helminths. There is some question about whether in some of the studies with mepolizumab, or one of the approval documents for mepolizumab, there were several cases of patients developing herpes zoster. And it's not clear whether that signal's holding up or not. I actually, in most cases, have patients take a zoster vaccine before I start, especially in patients who are older.
Can I take a question online, if you would?
Sure.
This was, what do we know about the distribution of IgE levels in the anti-IL-5 and the dupilumab study? And would some of the patients with high eosinophils respond to mepolizumab?
So the question, so you read the question. I actually was making the point that patients with high, when they looked at the EXTRA study, which basically had the same entry criteria as most of the anti-IL-5 studies, when they looked at the EXTRA study, if you had high eosinophils, and they defined high eosinophils as greater than 260, you had a 32% reduction in exacerbations. And so I think that the answer is that it's potentially true that treating these patients with if we chose the same patients, that treating them with anti-IgE therapy might produce similar results. It's never been done head-to-head. The indirect comparisons suggest that it's possible that it might be not very different.
Maybe I can get to ask my question.
Sure.
Why do you think exacerbations is the big signal for all of these studies? Why is it more than what potentially could be frequency of need for bronchodilator use or dosing of reducing doses of your other medications? So the most consistent finding, I know there were small benefits in these other areas, but the most consistent finding, the big signal has been exacerbations. And my corollary of that is, do you want to speculate on why people with multiple exacerbations, 4 or more, might benefit from anti-IL-5 therapy, even if they don't have a lot of eosinophils?
I think that's a great question. I think these things are not totally disconnected. First of all, I didn't show it, but the first study done, I think, with dupilumab was a inhaled corticosteroid reduction study and showed that you could very much reduce medications. And I think that's related to the fact that corticosteroids are working in a very similar way, at least in terms of their effect on eosinophils, as the anti-IL-5 therapies. And the question as to why we reduce exacerbations, and so I think we do reduce the ability to use inhaled corticosteroid medications. The question of why why the effect is on exacerbations and not others. The other thing we're looking at is bronchodilators, which really produce smooth muscle relaxation. And I think what this is telling us is that eosinophil products are not that involved in directly producing smooth muscle constriction. And so when you compare these to drugs that produce smooth muscle dilatation, they're not there. It's the same thing as anti-IgE. If you thought about anti-IgE has a very negligible effect on FEV1, but reduced exacerbations. And I think that T2 side piece of it is really related to producing airway mucus. I think potentially maybe producing airway hyperresponsiveness to some degree, and actually producing symptoms. At least I find that the patients who respond tell you that they feel the effects, and they can tell you when the effects are wearing off.
All right. Well, thank you so much
Great.
for stimulating.